is not working, sorry. Thank you everyone for having me here. My name is Piranat from Rajavati Hospital in Thailand, and I also thank you for my mentor, Dr. Ashra. And here is another case of the cold disease presenting with massive subdural high exudation, occupying almost half of the inferior retina. And yes, here, sorry, next please. Here also have the light bulb configuration of the telangiectasia at the peripheral retina. At the presentation, he was 17 years old, and his visual acuity was light perception. So he was diagnosed with stage 3 cold disease. And at the first presentation, we initially treated him with the intravitreal injection of the bevacizumab and make another follow-up in the next 1 month. And after 1 month, we perform the laser and intravitreal injection. So next slide, please. A total 1 year, we give him like 3 sessions of a laser treatment and 3 intravitreal injection. And after 1 year, we can see that the subretinal high exudation starts to decrease, and his visual acuity still remains stable at light perception. But after 2 years, his visual acuity came up to 5/200, with decrease of the subretinal high exudation. And the last follow-up is 7 years after the treatment. His visual acuity at 3/200, with the fibrotic scar at the fovea, and almost of the subretinal high exudation was completely gone. And we performed the angiography, and luckily it showed no leakage but some staining at the fibrotic scar. Next slide, please. And for the conclusion, this is an example case of the resolution of massive subretinal high exudation after cold disease treatment that can be achieved only by intravitreal injection and laser treatment without any invasive procedure. Thank you.
If you could stay here in the seat. Thank you. The next rapid fire is Dr. Devin Cohen, incidence and risk factors for exudative retinal detachment following laser photocoagulation for ROP. And if Dr. Alasami, if you could come to the front.
Hi everyone, thank you for the opportunity to speak today. As Dr. Lee said, my name is Devin. I'm a PGY4 resident at Shea Eye Institute and Children's Hospital in Philadelphia. And my presentation regards risk factors for exudative retinal detachment after laser for ROP. And these are my co-authors. So exudative retinal detachment is a rarely reported complication after ROP laser. It's only been reported in small case reports and case series, and the risk factors, thus are poorly understood. So we set out to perform the first comparative study looking at patients who developed an ERD after ROP laser to those who didn't, and paying special attention to the demographic, clinical, and procedural factors that have been hypothesized to potentially play a role. So we did a retrospective cohort study of infants receiving ROP laser at the Children's Hospital of Philadelphia over a 6-year period. All patients were treated according to standard criteria and lasered in a near confluent fashion from the avascular border to the aura 360 degrees. And the risk factors that we assessed on retrospective chart review were race, birth weight, gestational age, postmenstrual age at the time of treatment, the laser settings that were employed, whether or not the patient had a prior anti-VEGF injection prior to the laser, their oxygen status at the time of treatment, and as well as basic lab values such as their CBC and bilirubin levels. 149 infants were included in the study, and 6 infants had ERD complication after laser, the 4% incidence rate. And the only significant risk factor that we saw of those factors that we studied was the race of the patient, whereas all 6 patients who developed an ERD were of African American or Hispanic descent, and thus none of the 78 patients who were not of African American or Hispanic descent experienced this complication. So the possible mechanisms that we thought of that may contribute to this in these individuals, first and foremost, is the higher density of choroidal melanin in these patients, possibly leading to increased laser absorption, and then the secondary inflammatory and ischemic effects that could potentially lead to an exudative result. And then as well as we speculate that it could be more challenging to discern the aura in these patients with a more darkly pigmented fundus, and whether or not that could lead to incidental lasering anterior to the aura and lead to an ERD. So conclusions from this is that, as we know, ERD is an uncommon but observed complication after laser for ROP, and it's important to minimize laser power to the desired burn and pay special attention to the pigmentation of the fundus when doing so, and also to carefully avoid lasering anterior to the aura, especially in those patients where it might be more challenging to discern. These are my references. Thank you.
Next will be Dr. Ahmed El-Saheni, Norrin translocates the nucleus to activate wind-independent cellular functions.
Thank you for giving me the opportunity to present my work here. My name is Ahmed. I'm an MD PhD student from the University of Toronto, and I'd like to talk to you about our work understanding unexpected mechanisms behind NDB protein. The next slide, please. So I have nothing to disclose. So this is basically the known mechanism by which NDB works in several genetic diseases. So we have the protein, which binds surface receptors on the cell, and this leads to cascade wind signaling, which basically, as you can see here in the wild type, you can see that there is like a good vasculature architecture, but when you knock down NDB or its receptor, you get disruption of this. That was the initial observation under NDB, and it's involved in many genetic diseases like Coats disease, Norrie disease protein, Norrie disease, and fever. But we and other groups discovered that it has many other functions in the retina and outside the retina. Next slide, please. So here we wanted to investigate what other mechanisms are underlying this protein function, and we found very interesting results in which we discovered that the protein does not only work through surface receptors, but it can also make a very interesting decision to go inside the nucleus. And so, as you can see here, each one of these little red dots is basically like the protein binding its important protein that goes to the nucleus. We were able to image that with advanced BLA cellular cell biology techniques and very high MAC confocal. And then when we disrupted this process, we were able to shift the protein to go outside the nucleus and go outside. So we think that this can be a very interesting therapeutic approach. Next slide. These are my references, and I just want to say that this work is in the process of publication at Nature.com, so you can check it out.
Thank you. Next, Dr. So-Sing Lai, foveal degradation and macular hole in Coats disease. Also, this was supported also through a grant from the Jack McGovern Coats Disease Foundation, and also if Dr. Singh could come up to the other podium.
Thank you. Thanks for having me here. So I'm Zhuoting Lan from Taiwan. I'm a vitreoretinal surgeon, and this study was conducted during my research year at Duke. Here are my disclosures. So today, I would like to bring your attention to a unique macula condition that occurs in pediatric patients with Coats disease, but may have been underestimated in the past, until we carefully evaluated the macula condition using OCT. So here are some examples of this condition, which we call foveal degradation and macula hole, the FDMH. The arrows pointed out the macula full thickness macula tissue loss in FDMH. And in our study, FDMH was identified in more than 30% of the patients with Coats disease that have a good quality OCT. And we identified two OCT features associated with FDMH. The first is subfoveal nodule, and the second is vitreous band connection. For subfoveal nodule, 100% of our cases with FDMH had a subfoveal nodule. And in our series, we did identify one case that had a full thickness retinal tissue loss, but without nodule. And in that case, there was a typical vitreomacula traction OCT feature. And in addition to subfoveal nodule, we can identify vitreous band connecting to the nodule through the full thickness retinal tissue loss in more than 70% of our cases. And these two features may have been associated with the development of FDMH. We are currently studying the clinical significance of FDMH, and we believe that more study need to be done, and we need to pay focus on the macro condition in Coast disease patients with more OCT to evaluate the possibility of FDMH occurrence. With that, I would like to thank my mentor, Dr. Toes, and Darcy Lab for helping me with this study. I would also like to thank Jack McGovern's Coast Disease Foundation for their generous support on this project and the NIH triple grant. Thank you.
Our next presenter is Samar Rajan Singh, Anatomic Outcomes of Chandelier-Assisted External Drainage for Globe Salvage and Advanced Coast Disease.
Thank you, and thank you to the organizers of this meeting for this opportunity. And thanks to Dr. Jumper for referring to my editorial where I said less is more. I'm probably going to straddle on that line between less and more in this. Next slide, please. So these are basically cases of stage 3B and stage 4 Coats disease, which we call as advanced Coats disease. So in this, we report the anatomical outcomes for globe salvage in these patients with the technique that I have been evolving with time. So the initial methods, technique that I used was to do a 360-degree peritomy, make an anterior chamber maintainer in the inferior temporal quadrant, drain it about 10 to, please go back to the previous slide. Drain it about 10 to 12 millimeters from the limbus with a direct scleral cut down. And once that straw color fluid stops coming out, go in with the chandelier and do a good cryotherapy all around. So that was the initial technique, and some of the complications in the initial 5 to 6 cases, as you can see in the last row, was that extensive lid edema, because majority of these cases would have almost a 12 clock hour involvement with telangiectasia, so we would do extensive cryotherapy all around. And after the first 3-4 months it looked very good, and beyond that the vitreous fibrosis started to develop and almost a stage 5 ROP-like picture. Some of those children used to come back. So I modified my technique subsequently, and also a lot of these children would require squint surgery later on. So opening up the entire conjunctiva, fibrosing it was a little detrimental for that. So now what I do is place a traction suture at the temporal limbus with a duct rod, open a localized conjunctiva where I want to drain it, then make another port along with the chandelier and do a direct continuous mode painting of those vessels, and probably if the retina is properly attached, do a scatter laser along with, and coat vitrectomy only in those cases where there was significant vitreous fibrosis at that point of time. So this was the technique, and go to the next slide please. So we had about 11 cases in this series, 9 were stage 3B and 2 had stage 4. As you can see, they were very young children, mean age of presentation around 3 years. And 9 of them had complete resolution of subretinal fluid, while 1 had a partial resolution, and 1 that you can see in the last row in the images, that was persistent subretinal fluid. And additional procedures like epiretinal membrane removal, laser photocoagulation, repeated, and cryotherapy were needed in only 4 of these eyes. And no eye required enucleation, and we could get 100% globe salvage, which was the target that was initially discussed with these patients. And we have a mean follow-up of about 9 months that is reported in this series. And just as Dr. Jumper was talking about placing a scleral band, so what we found in this was 2 cases who had, when we do the subretinal fluid drainage, if you get clear fluid draining out from your sclerostomy instead of that straw-colored fluid, that is likely an indication that the fluid that you're infusing in the eye is draining out, and probably you have a break or dialysis somewhere. So both these cases in which I had partial or no reattachment had that. So probably placing this 240 band in those cases because of the sudden decompression that happens that can cause a dialysis. Thank you.
And the very last presentation of the entire meeting will be the honor goes to Ling Zhang, the effect of Frizzled-4 agonist versus anti-VEGF on restoration of blood-retinal barrier function in murine disease models. And she is also an awardee of the Jack McGovern Coast Disease Foundation.
Thank you, Dr. Lee, and thanks the organizer, and thank you everyone for being here until the last presentation. I'm Ling Zhang from University of Minnesota, and I have no commercial relationships to declare. Basic research has shown that non-Frizzled-4 signaling is important in regulating retinal angiogenesis and blood-retinal barrier function. mutations disrupting neuron-frizzel-4 signaling are associated with several retinal diseases, including fever, Coats disease. Our lab has established T712 knockout mice mouse model with lack of deep layer capillaries and blood-retinal barrier defects. And recently, we tested a Frizzle-4 LRT5 antibody, which is a agonist for neuron-Frizzle-4 signaling, which can fully restore blood-retinal barrier function and retinal angiogenesis in T712 knockout mice when treatment at developmental stage. When treat the T712 knockout mice at adult stage, the agonist doesn't restore retinal angiogenesis, but partially restores retinal barrier function. So the remaining leakage in the retina might due to hypoxia because of lack of deep layer capillaries. And our additional data shows that both the agonist and the anti-VEGF reduce albumin protein extravasation in this model. And whether the combination of the agonist and the anti-VEGF is synergistic in this model, and which one is better to restore retinal vascular leakage in different neuron disease model. And our research will address these questions. And please go to poster 35 to get more information if you still have time. And at last, I'd like to acknowledge Jack McGarvin, Coats Disease Foundation, for supporting this research. And thank you very much.